So let's jump right into the IL-12/23 inhibitor, the classic one, Ustekinumab. So this is a human monoclonal antibody, and it binds to the P40 subunit, and it binds actually, that P40 subunit is found rather both on IL-12 and IL-23, and it inhibits the activity of both, as Kevin was talking to us earlier about. We started out thinking this was a molecule that blocked IL-12, and lo and behold, around the time the molecule was developed to block IL-12, they started saying, oh my goodness, there was some basic science work which taught them basically. Looks like it actually blocks two molecules. Very interesting. You know, I think that the development of drugs for psoriasis has been very remarkable in that usually you have basic science discoveries and then you try to translate them into clinical work. And in the world of psoriasis, we've kind of turned it on end, and that's part of the reason why there's so many drugs and why there continue to be so many drugs, because we're starting to learn things the other way around. Like we're treating patients with drugs and then we're finding out, wow, that molecule might be important, that might be more important than we thought it actually was. So I think it's very instructive. And what's interesting that's starting to happen is that we have so many drugs, as you said, Tony, we have too many drugs. We're too lucky, if you will. And I've already heard several people come up to me and say, God, there's so many goddamn drugs. What do you do? How do you figure out which one? And, you know, the answer is, you could start with a simple one, you know, some of the earlier ones, like we were already talking about. One of my colleagues spoke about a class of drugs earlier. You know, there's not a right answer. There's not guidance. The National Psoriasis Foundation had a set of guidelines that came out 8 or 9 or 10 years ago, and they're getting around now to putting out a new set of guidelines. Those guidelines are still not going to tell you, pick A, pick B, pick C, here's when you pick A, here's when you pick B. They're going to tell you how to use the drugs, but they're not actually, you know, there's not a cookbook approach. I'm sorry, you know, medicine doesn't typically, well, some fields in medicine actually, you know, if we were cardiologists, they've done a clinical trial for every clinical question, it seems, right? They have 40,000 patients to study them and see whether or not this drug increases or decreases the risk of myocardial infarction. Dermatology, we don't have that, and we're not likely to ever have that, I would say. And so I don't think that we're going to get the level of guidance that perhaps some people crave to make things simple so you can figure out how do you do it. We're not here to make it simple, I'm sorry. We're here to learn what's going on. We're here to help our patients, but I don't think we're going to be able to make it actually simple, at least in the short term. Perhaps in the long term we will. So Ustekinumab is indicated for the treatment of adults 18 years or older with moderate to severe plaque psoriasis who are candidates for photo and systemic therapy. I should have updated this slide. That's not true. It's actually also indicated for kids, for teenagers aged 12 and up. It just got that approval maybe 6-9 months ago, maybe. I might be wrong. So the dose for adults is for patients weighing less than 100 kilograms, 45 milligrams at baseline, and then 4 weeks later repeat that dose, and then 45 milligrams every 12 weeks. That's the way it was studied in the trials. For patients who weigh over 100 kilograms, your usual psoriasis patient, right? That's one of the major comorbidities of psoriasis is obesity. For those patients, the recommended dose is 90 milligrams baseline, repeated 4 weeks later, and then repeated every 12 weeks thereafter. So what's nice about Ustekinumab? I think it has high efficacy. The infrequent dosing is considered very, very nice by many of our patients, particularly the ones who are needle shy and they want us to do it. They want to come into the office and they want us to give them the shot. I think it has an excellent safety profile, and it doesn't really have any specific disease precautions. You know, for example, with the TNF inhibitors, you have to be concerned about congestive heart failure, multiple sclerosis. With the IL-17 inhibitors, as you'll hear in a little while, you have to be concerned about inflammatory bowel disease. So there aren't any specific precautions. Like all of the biologic agents, you need to be concerned about a possible increased risk of infection. And so, as I said, the in-office sub-Q dosing is if desired, but certainly many of our patients who are on this drug have already been on another drug before, and they already know how to do a sub-Q injection on their own, and so many of them prefer to do it at home. It's kind of a balance, and I think many of us do both, and we think about it for our patients to decide whether or not they'd rather do it in office or we'd rather have them do it on their own at home. And even if they haven't used another sub-Q biologic drug for their psoriasis, we can certainly teach them here just as well as we can with any other drug. So what I would consider one of the disadvantages of Ustekinumab is it's approved for psoriatic arthritis, as the enormous majority of the drugs that are out there and approved for the treatment of psoriasis are, but I think it's clearly less effective than most of the other agents that also have an approval for psoriatic arthritis, and it does not have an indication for the prevention of joint destruction, which is critical, I think, really, really important, because that's what we worry about in our patients with psoriasis. We worry that the 25 or 30% of them who may go on to develop psoriatic arthritis, we certainly want to prevent that from happening, and even more important than preventing them from developing disease is to develop disease that will destroy a joint, and that's very hard to predict in advance, again, as Kevin Cooper talked about this morning. So this is a trial where they compared Ustekinumab to Etanercept, and on the left, we look at the PASI 75 numbers. PASI 75 is a measurement of 75% improvement in severity of disease, and we see that Etanercept was less efficacious than either dose of Ustekinumab, 45 or 90. Same thing with PASI 90, where there was statistically significant difference in patients given either dose of Ustekinumab, and then basically by every criteria, Ustekinumab was better than Etanercept in this comparator trial. This was an old trial already published 8 years ago in the New England Journal of Medicine. So in terms of practical points, so it's approved by the FDA for week 0, 4, 12, and then every 12 weeks. But during the trials, they actually studied this drug at every 8-week interval, so 0, 4, and Q8. The results showed better efficacy in these patients without any increased safety signal. But the FDA is the FDA, and they do what they do. Like you heard before, for the pediatric studies, it took them, 8 years, 7 years to finally approve Etanercept for pediatric psoriasis. My biased opinion is the FDA is a rather conservative bunch, and they're rather cautious, and they're worried, and so they balance, they just say safety and safety and safety and safety, and the efficacy, Psoriasis is an unimportant disease. That's my biased kind of over nasty approach of what I think about it, which is, so what if you get better results every 8 weeks, and so what if in the short term the safety data didn't look any different? We're not sure, and we don't know for sure. So they approved only every 12 weeks, and in practice the problem is that many of our patients end up needing to be dosed every 8 weeks. And this is often a big challenge to get insurance coverage for this. I had a guy who was, he actually had erythrodermic disease, which is this is not approved for, but neither is anything else approved for erythrodermic psoriasis. I started him on one of the TNF inhibitors. I added methotrexate, nothing. I switched him, I took him off the TNF inhibitor, and I put him on Ustekinumab, and I was like, oh, great, it's working, every 12 weeks. And then I asked the insurance to approve it for every 8 weeks. Guess what they did? They wrote back and they said, he can no longer have the drug. But fortunately, we fought it, and I wrote a long letter, and I yelled and I screamed, and it worked. But that's about dollars. It's always about dollars, unfortunately. But had the FDA approved every 12 and every 8 weeks, we wouldn't be in this scenario. Okay, so Tony alluded to this PSOLAR registry. I wanted to take you through it, and the reason is because the company that developed Ustekinumab was the company that developed the PSOLAR registry, Psoriasis Longitudinal Assessment and Registry, a big multi-center observational study looking at people on systemic drugs for psoriasis. The thing that's really, really cool about this registry was that until this registry came along, the FDA, after a drug is approved by the FDA, they say, okay, we like this drug, it's approved, but we got to watch it over the long term and make sure that it stays safe in a larger group of patients. Makes sense. But all of the registries until this point were always just a registry for drug X alone, people on drug X, period. This is a registry where they allowed people who were on Ustekinumab to go in their trial, but they also put people on any other biologic, so that all the other TNF inhibitors, and actually this registry started in 2009, and it has more than 12,000 patients in it, people who had been on old drugs, Amaviv, anybody ever hear of that? Reptiva, or some of the old drugs that are actually off the market now, they included patients who had been on that as well. It began in 2009, and it's going to go to 2021. And Tony talked about, was it only one study you mentioned from PSOLAR? There are 14 or 15 publications out of PSOLAR looking at all kinds of things. I'm going to take you through a little bit through it just to tell you and try to compare what they've learned from some of these studies. So basically, one group is Ustekinumab, the other group is Infliximab and Golimumab. Golimumab is another TNF inhibitor that's approved only for psoriatic arthritis. It's not approved for psoriasis. It really doesn't do hardly anything for psoriasis. And both of those, the reason they're in that group is because they are also made by the same company that makes Ustekinumab. And then the next one was other biologics, Etanercept, Adalimumab, and then Alefacept and Efalimumab. I think that's probably almost all of them. And then the non-biologics, typically methotrexate, but cyclosporin, acitretin, anything else. So anybody on any systemic was eligible to get into this registry. And this is just, it's a registry, and there's potential sources of bias. And, they have rules about when someone's called a Stelara, a Ustekinumab patient in the trial versus when they're called another drug. I'm not going to take you through all of the details, but I'm going to take you through a little bit of the data. Is there a pointer up here? I seem to not know how to do that. The cursor will point? No, that doesn't point. That just moves it. Shake the mouse. Okay, there we go. Shake it up, baby. Twist and shout. Okay, so serious infections for Ustekinumab. All right, so this is on the, what side is that? That's the left. Okay, so this is rates per 100 patient years. And this is over a few-year period, three years back, a few years back. And basically, these numbers are all the same. I spent several hours trying to make that black-white and failed miserably, so I know nobody can read that, but tough luck on you. But these numbers are the same. Okay, so basically, in the PSOLAR registry, serious infections for Ustekinumab were no different than in all the trials for Ustekinumab, about the same. The numbers are 0.8, 0.8, 0.9, 1.1. So those numbers don't look any different. And so this is over a year, 2, 3 years, and this is over 5 years. And this is all of the clinical trials, the phase 2, the 2 pivotal trials, and the comparator trial. All right. So this is now comparing to the other drugs, okay? So again, here's Ustekinumab. Here is the other sponsor biologics, largely Infliximab. This is the other TNF inhibitors and the T-cell agents. And this is methotrexate, cyclosporin, and this is everything. So actually, if you look at the numbers, it looks like the rate of serious infections for Ustekinumab is actually lower than at least certainly this group, which is made up largely of Infliximab, the intravenous drug, and it's not a surprise. We sort of already know that, all right? And maybe it's even higher than the other TNF inhibitors, maybe. There's not great statistics to compare these definitively, but it's reassuring that Ustekinumab's rate of serious infections certainly is not any higher than any of the other agents. What about malignancy? Take out non-melanoma skin cancer, and the numbers are quite low over 1, 2, and 3 years. What are those numbers? They're around 0.5 rates per 100 patient years, and then in the clinical trials over 5 years, 0.6. So really no difference, no significant elevated risk of malignancy over time. Systemic malignancy, right? And then this is the comparator, maybe not as nice as the previous one that it looks so much lower, but certainly no higher than any of the other groups when you compare Ustekinumab to any of the other groups of patients treated with other systemic therapies for psoriasis. What about MACE? What is MACE? Major Adverse Cardiovascular Event. And this is heart attack, stroke, and cardiovascular death. And this came up for Ustekinumab. I'll talk about this other drug in a minute called Briakinumab, which was another IL-12/23 inhibitor. And it had several cases of MACE, which caused it to actually not go forward as a drug to be used. So it raised the worry that this IL-12/23 inhibitor might have MACE events associated with it. Not true. 0.2, 0.3 per 100 patient years in the PSOLAR ever exposed, and 0.4 in the clinical trial. So really no evidence of increased risk of MACE. And then this is comparing to all the other drugs. Again, probably no different than any of the other groups of drugs. All right, so what's new going on in Ustekinumab? It's been approved for Crohn's disease in the last year or so. It's dosed differently. They get an IV loading dose at 6 milligrams per kilogram. So if somebody weighs 100 kilograms, they're getting 600 milligrams of Ustekinumab, so a whopping dose. And then they get 90 milligrams every 8 weeks. It's in trials for ulcerative colitis. I think it's phase 3, if I'm not mistaken. And it's actually also in trials for lupus, for systemic lupus, which I think is quite exciting, because every single drug that seems to go into lupus trials seems to hit some kind of a dead end and die. They're really not finding a whole lot that seems to work well for the treatment of systemic lupus. So perhaps Ustekinumab will be an agent that will have a place in the treatment of SLE. So this is the other drug that I was alluding to, Briakinumab. So it was developed after Ustekinumab, and the earliest data said, wow, this is an amazing drug. It has such great efficacy, way better than Ustekinumab. But then they looked a little more carefully, and they started looking at pooled safety data from multiple trials, and all of a sudden, oh my God, increased infections, oh my God, malignancies, oh my God, major adverse cardiovascular events. Sayonara Briakinumab. That was the end of it. They're actually studying it in Crohn's now. So I think I made a point the other day when I was talking about bullous diseases that you sort of have to think about a drug when you're thinking about a drug and what its side effect profile is. What disease are you using it for? So Briakinumab's side effect profile was so severe that none of us would want to think about having it for the treatment of psoriasis. Crohn's is a lot more serious disease, and there's a lot more people who would potentially accept these potentially rare risks. And so that's why the company is taking the drug forward and looking at it in Crohn's, because they have a lot of data on it, and you didn't want to just throw it in the garbage. I think sometimes the pharmaceutical companies will take a drug and just say, that's it, we're done with it. Here they said, that's it, we're done with it for psoriasis, and they thought, could we find another place for it? And so it's in trials for Crohn's. All right, switching gears from the IL-12/23 to this oral agent, Apremilast. So this is an oral immunomodulator, and it blocks the activity of phosphodiesterase, and it modulates the production of multiple cytokines. So unlike the biologics, which are proteins which we need to inject because if we swallowed them, our pH of 2 in our stomach would destroy those proteins, destroy their tertiary structure, they wouldn't function. This is an oral agent. And what this does is immunomodulates multiple cytokines as opposed to an IL-12/23 inhibitor which blocks 2, or the TNF inhibitors which block 1, or the IL-17 inhibitors that we're going to hear about which block 1, or the IL-23 pure drugs which block 1. So this drug, Apremilast, modulates the production of multiple different cytokines, including TNF-alpha, IL-2, 10, 17, and 23. So let's talk about some practical points. It's an oral agent. Patients love oral agents. A lot of people are afraid of shots or don't want shots. It's non-immunosuppressive. How do we define that? We define that by the fact that in the clinical trials, there wasn't a whole lot of signals that demonstrated any immunosuppression. There was no tuberculosis. There was no increased risk of infections. There just wasn't much to demonstrate that we have to worry that this drug is suppressing the immune system. You dose it at 30 milligrams twice a day after an up titration over, I think I said a week. I think it's 6 days, actually. except for patients who have significant renal insufficiency. They have a GFR under 5, under 30 milligrams per ml. We dose them at 30 once a day, and they have a slightly faster titration. No laboratory monitoring is required. That's the savior for this drug. This is why so many dermatologists really like this drug, is because the absence of laboratory monitoring and it being an oral drug. And that's why the patients and the doctors like it, okay? And it's approved and has efficacy for both skin and joints, psoriasis and psoriatic arthritis. So this is a summary of the 3-year safety data out of the original trials, the rates of major cardiac events, malignancies, depression, suicidality, no difference, no opportunistic infections, reactivation of TB or relevant lab abnormalities, safety data from the psoriasis and the psoriatic arthritis trials look pretty good, even in the patients who are on concomitant methotrexate. And the safety profile over whatever that is, 3.5 years, looked very nice. So the main issue with this drug, intolerability, is GI side effects, nausea and diarrhea. These happen pretty early on, within the first couple of weeks, but usually most people don't stop. In the trial, most people didn't stop it because of that. So these are just some of my suggestions from some of the data that the company has developed, and some of the things that I do personally when I'm on. First thing is to talk to people and give them warning. It's a balancing act, though, because some people, it's the power of suggestion. All you have to do is tell them this is going to bother your stomach, and then you are hosed. It bothers their stomach. But other people, you don't tell them about it, and then you don't have the opportunity to intervene when it occurs. So it's a hard line. So typically that problems will happen in the first couple of weeks, and they only typically last a couple of weeks. So if they have diarrhea, I'll advise them to hydrate, to take it with food, to eat a smaller meal, to avoid caffeine, dairy, artificial sweeteners, maybe over-the-counter fiber, maybe loperamide, maybe Pepto-Bismol. All right, for nausea, kind of the same stuff with, in addition, minimizing their fluid intake, decrease exercise after eating or taking the drug, and maybe even consider some Benadryl for the nausea. And then the other thing is to alter the dose. What I really try to do, which I fail at, I think, most often, but this is probably the most successful thing, is the moment the patient says something's going on, stop and get me on the phone. That's hard to do, though, okay? And as much as I try to teach them who to call and what number and what to say, and it just doesn't happen. And more often, once they get this and it lasts for a little while, in my hands, they usually just say, the hell with that drug, I'm not taking it anymore. One other thing that's interesting about Apremilast is that they've seen some weight loss. Patients on Apremilast with more than 5% weight loss, 19% of the patients at 52 weeks and 22% of the patients at 3.5 years had weight loss. Sounds good to me. Psoriasis patients are overweight. Don't we want them to lose weight? I haven't seen much of it. I know lots of other people have. I haven't seen as much of it as I wish I did. So this is a trial of Apremilast for patients with moderate psoriasis, patients with a lower BSA between 5 and 10%, and a SPGA of 3 on a scale of 0 to 5, and it was a pretty big trial. And basically the results were that 48% of the patients reached a positive outcome. I won't bother you with the details. It wasn't a PASI, because PASI's crappy when you get down to lower body surface areas. But it's good because we don't really have many systemic drugs that actually have any data, all right? This is what Dr. Cooper talked about. This is a trial that we're actually doing, looking at monocyte biomarkers in Apremilast patients, and we're actually just about to start. I think this week we might be enrolling our first patient. So if anybody wants to put a patient on Apremilast and they can't get them on it, they can get 4 months of free Apremilast if they just give us a call. And we're going to look at these monocyte biomarkers, the doublets, the monocyte platelet aggregates, and the monocyte subsets. And as Dr. Cooper told you earlier, we think of monocytes as kind of sentinels or markers for inflammation. They actually have been shown to help predict the Framingham risk of cardiovascular disease in psoriasis patients. Apremilast has been looked at in a few other diseases, ulcerative colitis, dosed it the same way, 30 twice a day, and it has promising results there with no new safety signals. And the one that I think is even more intriguing for us in derm is Behçet's. This was a trial done mostly in Turkey. That's where Behçet's typically lives. 111 patients with 2 or more oral ulcers. They got either Apremilast 30 twice a day or placebo for 12 weeks. And there was a significant decrease in the number of oral ulcers compared to placebo and decreased pain. And this was important enough that it made it to the New England Journal of Medicine. Finally, 22 seconds left. Keep going, baby. So other small molecules. I did a clinicaltrials.gov search of psoriasis and treatments, and I came up with 2,300 hits. There's a lot of action for psoriasis. So here are 4 drugs that are, well, the first one, tofacitinib, which is Xeljanz, which is approved for rheumatoid arthritis, and you guys have heard about it. I'm sure you heard the other day about it for alopecia areata and vitiligo. They completed the phase 3 studies. It was at a higher dose than is approved for RA, and the FDA said, again, same story I told you earlier. Higher dose, they were afraid of it. 3 other drugs. One is what's called a TYK2 inhibitor. It's in the JAK family, starting phase 3. Baricitinib, a different JAK inhibitor, perhaps will start in phase 3. And then something called an ROR gamma inhibitor, which is an oral IL-17 inhibitor, but I don't know if that study has begun yet.